Hi guys, we're going to talk about antibacterial agents and a number of other infectious disease things. Now, I'll preface this with a lot of these items might be things you would seldom see in practice. And so it's kind of hard to draw the line because some of this stuff you can see. You can have women in labor and delivery situations go into severe sepsis, which I think it's good to know what type of treatment you'd be looking at, even if you aren't necessarily making the decisions directly. Hopefully, you'd have infectious disease on board or something like that. But in your private practice, you could see some community-acquired things too, like community-acquired pneumonia, UTIs, stuff like that. So I think it's good to cover a wide breadth of things, and I'll certainly try and tailor these slides into during our discussion about what I think you need to know and what's most important. So antibacterial agents, we most commonly refer those to as antibiotics, even though the term antibiotic is probably technically a little more broad than that. Whatever, it doesn't really matter. When we talk about antibiotics, you're talking about antibacterial agents. And this is going to be our most common group of drugs when we talk about different types of infectious disease. Antibiotics usually operate on one of two main mechanisms, although there are some other ones too. There's a couple other classes that work differently, but pretty much you're looking at working on breaking down the bacterial cell wall or getting inside the bacteria and preventing proteins from synthesizing. So either one of these strategies is effective and effective at different types of antibiotics. So for example, cell wall inhibitors tend to work really well against most gram-positive agents, but sometimes gram-negative agents have mechanisms that don't allow that. But then there are some cell wall inhibitors that do work on gram-negative. So anyway, we're going to get into all this in more detail, but that's sort of where they fall into two different groups as far as the mechanism of action goes. Most antibiotics are pretty well tolerated and don't have a ton of side effects. We'll talk about some of the specifics as we get into the agents. Resistance is always a concern. And so good stewardship of our antibiotic resources is really important. It's important for us to know how to use antibiotics appropriately, know how to dose them appropriately, know the duration to use them, know when to say, this doesn't need an antibiotic. That's just as important to not prescribe antibiotics as it is to prescribe them appropriately. So that's something that as healthcare providers we need to take seriously because these are a precious resource. And the more we abuse antibiotic use, the more resistance we're going to get. And if we lose certain classes of drugs, we can end up with infections that simply aren't curable. Just some resources to go to on your own or in your practice if you're looking for some things to supplement this information with. IDSA is the more or less gold standard when it comes to infectious disease related guidelines. So if we're talking about community-acquired pneumonia or things like that, IDSA's published guidelines are sort of the end-all be-all. Now, certainly in between guideline publications, different evidence can come out, new drugs can come out, so it's not always the most up-to-date things because guidelines tend to be pretty lengthy and they aren't always updated on a regular intervals. But IDSA is still a great resource. They have a lot of good things on their website, from antimicrobial stewardship pointers, and of course to their more published guidelines that they're more famous for. The Sanford Guide is something that you might see. It comes as a little small paperback book that's maybe about 3 inches by 4 inches. And the nice thing about the Sanford Guide is it has pretty comprehensive bacterial susceptibilities cross-referenced to different antibiotics. So what it'll show you is, let's say you have an infection that comes back as E. coli, and your patient has a bunch of allergies that they're reporting. You're like, well, what am I supposed to do? I don't know all the first-line therapies she's allergic to. What else covers E. coli? You can look at the Sanford Guide, find E. coli, and look at what drugs theoretically cover it. We'll talk about some antibiograms too and things like that, and how those come into play. But that's a great resource. It's sort of a general antibiogram that's pretty well published and well referenced. The CDC, MDH, we talked about vaccine schedules there. They also have lots of other tidbits, patient education things for various diseases too. Other paper references are listed there. I don't really use these a lot anymore. Clinical specialists, of course, you can reach out to infectious disease providers, and pharmacists are growing more and more into this role. And some places may have pharmacists who specialize in infectious disease, like my hospital. All right, antibiotic effects. So this gets a little complicated. I'm going to try and strain it down for you into what I think is most important. A couple different terminology. First of all is mean inhibitory concentration. I'll show you this on the next slide in a more practical application. But mean inhibitory concentration means like what it sounds. It's the lowest concentration you have to have of the antibiotic in somebody's bloodstream to be able to successfully kill bacteria. And so if your bacteria's MIC is really high, it means that you have to get a blood concentration really high to kill it. And a lot of times that's not practical because you're going to end up overdosing your patient and causing some really nasty side effects. In some cases, it's just not possible to even consider doing that. So that's where a lot of susceptibility data comes from, because if they do a test on a specific bacteria and it says, well, this bacteria isn't being very affected by this particular drug, it's going to have a really high MIC. That's going to mean it's generally resistant to that bacteria, and we aren't going to use that bacteria. I'll show how this plays out on a lab report in a second here. Bactericidal means bacterial killing. So this is the more common type of antibiotic. It's usually associated with faster response rates. I say faster killing because it directly kills the antibiotic, or the bacteria, I should say. Usually these are a couple of different aspects to them. So a lot of times they're concentration dependent, so meaning that really we just need to get a certain concentration. If you're above a certain point in the MIC, you're going to get good killing, and that's it. We want to focus on the area under the curve. So if you've got a graph and you're looking at your total response, you're looking at really big peaks because you're targeting very high concentrations. Now the problem with targeting a high concentration when you're giving antibiotics is you also put your patient at risk for more side effects. So time-dependent antibiotics are usually favored because you really just have to be slightly over the MIC, so maybe 2 to 4 times MIC. You just have to sustain that for a certain amount of time. That's really all it is. You'll see some hybridized theories too, not really worth talking about. Bacteriostatic is slower killing, and it's what it sounds like. What it does is it prevents the bacteria from replicating, but it doesn't directly kill the bacteria. It's still useful, and we do have antibiotics that work this way, but bactericidal usually going to be more effective overall and faster efficacy anyway. You might hear about something called post-antibiotic effect too, which is a little bit complicated as well, but the basics behind it is that if you give a really high concentration of something, you kill off so many bacteria at once. If you give a really big dose of something, kill off a ton of bacteria at once, it takes the bacteria a really long time to regrow whatever's left. So at that point, you have sort of a delayed regrowth in bacteria where the infection is at bay for a bit. And that's called a post-antibiotic effect. This is something you'll see from laboratory reports. So this is a urine culture. So we can see a couple different things here. First of all, it's telling you the results are abnormal. It's saying this is your finalized result, so you can't expect any more susceptibilities after this. It's from a urine specimen. It's clean catch, and it's growing greater than 100,000 E. coli. Now, different organizations use different predetermined sets of antibiotics they test to. So, for example, they buy a test kit from a company that puts specific antibiotics. So, for example, this is what our hospital uses for urine cultures, and these are the specific antibiotics it looks at. Is it ideal? No, there's probably some tweaking we would do if we could build our own, but it's pretty close. It works for the most part. And what this is doing is when they culture bacteria, they're putting it on a tray, they're putting these little discs on it, and the discs radiate the antibiotic, and depending on how much growth the bacteria is getting within the radius of that disc, that's how effective it's going to be. So if there's no growth at all around a disc, it means that's a really low MIC. You aren't going to need a lot of that antimicrobial to kill that bacteria. If there's growth right up to the disc, it might mean it's heavily resistant. So the lab has all kinds of techniques they use to measure this type of stuff, and they have specific standards they apply this to. But the point is, when you're trying to interpret this, you're going to look at a couple things. So first of all, the number of bacteria. If you saw, so this is pretty common, greater than 100,000, mean there's quite a bit of bacteria in the urine. If you saw a 10 to 50,000, that's probably not a lot. That could just be a contaminant of some kind. If you saw 50 to 100,000, that's probably a decent amount. There's really no cutoff, and ultimately it comes down to how symptomatic is your patient. If your patient's having symptoms and they don't have a lot of bacteria growing, you probably still are going to treat them as if they had a lot of bacteria growing. So it's a bit of an issue when it comes to asymptomatic bacteria. So if you're wondering how much bacteria am I looking at, is it 10 to 50,000? They're asymptomatic. Do I treat them? Ooh, that's tough, especially with pregnant patients, because pregnant patients are one of the few patients we actually treat asymptomatic bacteriuria. So in that case, is a small amount of E. coli worth treating? Most providers would likely err on the side that they're doing it. Now I'm getting a little bit outside of my scope of practice, but this is kind of what I do for a living. I follow up on a lot of these cultures. So anyway, I'm getting on tangents, but let's get back to these numbers and what we're looking at. So what you're seeing on this column with the number is the MIC. So this is saying that your MIC for ampicillin has to be over 32. And in that case, it's just not possible to get over 32. You're resistant. Ampicillin and sulbactam are unison. If you are getting to an MIC of 16, you might get some success, but that's still saying it's intermediate as far as resistance, because you do have to get your concentration quite high to get a good killing rate with those. So for the most part, we think of resistance and intermediate as kind of the same. Generally, won't use an intermediate drug because we should have something susceptible we can use. So let's move down the list a little bit further. Let's talk about some more specific things that are useful. So Bactrim is something that's historically been used for UTIs a lot. That's susceptible here, or sulfamethoxyl trimethoprim. We can see that our fluoroquinolones, Cipro and Levaquin, ciprofloxacin and levofloxacin, are both resistant. And we can see that all of our cephalosporins are susceptible. A drug that's really nice to use in a lot of groups of patients, specifically young, healthy women, nitrofurantoin or macrobid, here is showing intermediate resistance. So this is a great way. We're prescribing a lot empirically. You have a patient in your clinic, you think they have a UTI, you prescribe them something, you do a UA, urine analysis on them, it looks particularly suspicious for a urinary tract infection. Prescribe them something empirically, they go home, they take it a day later, you get the culture back, you call them, oh, that nitrofurantoin I prescribed you, probably not the best. Let's switch to a cephalosporin. So that's something that's pretty common in practice. We try our best to do things that are the most appropriate empirically, but you can't always get that result immediately. So it's not uncommon to have to call a patient and tell them to stop one antibiotic and start another. All right, stewardship and resistance. So I talked about this a little bit already. A couple ways we can be good stewards is, first and foremost, know your local resistance patterns. So I don't know if I have an example of this on this slide set. Oh yeah, I do on the next slide. Antibiograms are your friend. Let's go here quick and look at the antibiogram. This is an old one from our hospital, but all hospitals publish this information. And organizations like the Minnesota Department of Health publish this as well. So you can see what's trending on a state level, and you can also see what's trending on your specific institution's level. And most institutions will publish a inpatient antibiogram and an outpatient, so you get both groups of patients, because inpatients tend to be sicker. You're looking at maybe more hospital-acquired infections potentially, and then outpatient would be more community acquired. So it depends on what you're looking at as far as your patient that you're treating at the time. But hospital antibiograms are really valuable. And what they show you is, this is very set up similar to kind of what the Sanford guide will show you, but it's more specific, obviously, to your place. And this is actually real data that your micro lab is compiling. So let's talk about E. coli. Let's find E. coli. Here's E. coli in the middle here. And let's look. So we're comparing that other urine culture. Let's go down to nitrofurantoin. So see, nitrofurantoin is 96% susceptible. That means that only 4% of strains are resistant or intermediate. That's pretty good. Most cases we don't, for example, this last urine culture, we could see that that's an anomaly. So the fact, going back to our hypothetical situation, if you prescribe somebody nitrofurantoin empirically without having a culture evidence, that's a pretty good choice, because you're 96% likely to cover that infection. In that case, you happen to be wrong. You're one of the 4%. That's unlucky, but it certainly happens. So don't get too hard on yourself if that occurs. But you can see here, if you're picking things, looking at different items, you can use this information to your advantage. And I highly suggest get familiar with antibiograms locally and with the health systems you're practicing in. Certainly going to come in handy when you prescribe for those infections. Oh, back to stewardship quick. Some other pointers. So antibiograms are a big thing. Don't ever use something you don't have to. Patients can be pushy about antibiotics sometimes. You got to hold your ground as a healthcare professional sometimes and say, nope, this is a common cold. You have a virus. You do not need antibiotics. Trust me, it's not going to help you. You're just putting yourself at risk for side effects. And I'm a big fan of not giving antibiotics in situations that are not appropriate, simply because you're exposing your patient to something they don't need, and there's a lot of situations where you can generate resistance doing that. So again, stewardship's really important with our antimicrobial resources. Broad spectrum doesn't mean better. So just because a drug is broader and covers more bacteria doesn't mean it's something we want to use. So you might look at your antibiogram and say, wow, I've got E. coli and imipenem covers it 100%. So why shouldn't I just use imipenem? It's always going to work. Imipenem's like a last line drug for severe gram-negative infections. It's one of our most powerful broad-spectrum antibiotics. So if you order that for a UTI for an inpatient, it's IV only, so it'd have to be an inpatient. You're going to get some kind of a call from somebody saying, what are you doing? This person has E. coli, it looks susceptible. Generally speaking, a rule of thumb, use the most narrow spectrum drug possible. The reason is we don't want drugs possibly causing resistance with other things in your body, other bacteria you have in your local flora. And as a good rule of thumb, we want to use a silver bullet approach if we can. Target a specific bacteria if you can. If you have to go broad spectrum, you do. There's no getting around that in some cases, but try and narrow your spectrum of activity as you get culture results back. So sometimes, sometimes we might start really broad spectrum and then have to narrow in once we get sensitivity data back, and that's certainly okay to do as well. Some other things to consider when you're prescribing antibiotics: your patient history. Have they been exposed to something, whether it's a family member, a friend? Is there some clue as to what they might have got? Like, if you have a person who's coming in with a lot of diarrhea and their friend that they just had dinner with had a C. diff infection recently, well, there you go. There's clues you can look into, of course, like that. Previous culture data. If somebody has frequent UTIs and you're culturing them regularly, using that data to your advantage, looking for trends, you can look at their most recent data and say, well, last time this drug worked great, and it was susceptible, so likely this is a good choice too. Or, whoa, last time nitrofurantoin was resistant, so I should probably pick something else. So you can think about it that way. Length of treatment. Again, duration is really important. Don't overdo it. Use the recommended durations. And sometimes you'll read a drug dosing guideline and it'll say, this is the package insert dosing. However, studies have shown that 7 days is a package insert study, but studies have shown you can use it for 5 days. Use it for 5 days. Use the lower settings. Those are pretty well studied and well proven. Allergies is always something that throws a monkey wrench in infectious disease. And sometimes people are allergic to everything except for, the most broad spectrum option on the planet, like a carbapenem, like imipenem. And so you end up having to use something that might not be totally appropriate for the average patient. But in this case, we want to avoid causing anaphylaxis. So therefore, we're going to do something broad spectrum. So that's something that always you want to take into consideration too. But on the flip side of that, make sure you're doing your due diligence and homework when you're vetting somebody's allergies. I can't tell you how many times I've gotten a response from a provider where they tell me, oh, I really want to use a cephalosporin, but they have a cephalosporin allergy. Can you recommend something else? And I go and look at their allergies and says, well, they took a cephalosporin, but it says they got nauseous when they took it. Well, as much as we don't like causing nausea in our patients, that's not a real allergy. And if that's an appropriate choice, that's still something that is definitely on the table. What we want to avoid are things that are really type 1 hypersensitivity reactions, which would be full-out anaphylaxis, or things like hives would be like a simple drug rash, probably not enough to avoid something. You could pre-medicate with antihistamine potentially. There's lots of ways to get around that, but the point is that you want to do your homework when you're approaching allergies. So don't just let that little flag on the computer tell you, oh, I can't do this. Actually look at what that is and ask the patient, hey, it says you had an allergy to cephalosporin. Have you ever had this particular one? No. Oh, you tried that cephalosporin and that was fine? Yep. Okay. Patients often have more information than what is in the chart when it comes to allergies, so certainly again, do your homework on that. Okay, let's start and talk about beta-lactams. Okay, so I promise I'll rarely ever show you chemical structures, and I'll certainly will never ask you to know a chemical structure, but the point in beta-lactams is that all beta-lactams are related, and they're related with this beta-lactam ring. So penicillin, cephalosporins, monobactams, and carbapenems are all categories of beta-lactams. And they all generally have the same mechanism. They break down cell walls, and they're bactericidal. They're time-dependent killers, meaning that we don't need to give people massive doses and high concentrations to get efficacy with these drugs. There's a ton of different agents in this group. You have very narrow spectrum old drugs like penicillin to the most broad spectrum drugs we have like imipenem. And that's all within the beta-lactam group. Bacteria have the capability sometimes to produce various beta-lactamase producing enzymes. So what a beta-lactamase is, it's an enzyme that the bacteria has developed and releases that breaks down that beta-lactam ring. So sometimes the more complicated the structure is, the more resilient it is to beta-lactamase. But sometimes you'll hear about, if you've ever read into any like superbugs or anything like that, you might read about the term like carbapenemase producing. Carbapenemase would just be a more specific beta-lactamase designed to break carbapenems down. And that would be a mechanism that bacteria have generated over time to work around carbapenems. So sometimes you hear about Klebsiella as one that has a carbapenemase producing strain that people get nervous about. Again, whenever you're talking about carbapenem resistance, you get kind of scared because that's one of the most powerful drugs we have for bacterial infections. But generally speaking, you can couple these with beta-lactamase inhibitors, and in fact, that's where some of the new drugs are coming out, where they're taking some of our broad-spectrum drugs like our carbapenems, and very more broad-spectrum cephalosporins, and coupling them with more advanced inhibitors of these enzymes so that they can the enzyme can get neutralized by an inhibitor. So basically, you're taking two drugs at once. One's inhibiting the enzyme that could possibly break down the other drug, while the other drug can do its job like it normally would. These drugs are pretty great as a group, I think. There's very few side effects with them as a whole. They're well-tolerated medications. They don't really have a lot of drug interactions, and for the most part, they're all very well-tolerated in both pregnant populations and children. Most of their dosing is more frequent, like 2 to 4 times a day, but some of them are once daily. This is just a diagram of the mechanism of action of a beta-lactam. So penicillin binding proteins are proteins that make up make up the cell wall. So they'll help build the cell wall. Now what a penicillin does, it's called a penicillin binding protein because penicillin originally binds to it. So what happens is this is making the cell wall, synthesizing it, everything's great with the bacteria. Then all of a sudden a beta-lactam comes in and binds to it, and then nothing can get made. And then that cell wall doesn't get completed, the bacteria dies. The other way we can do this is using something like vancomycin, which is a glycopeptide. This drug actually binds to the amino acid chain so that the penicillin binding protein doesn't have anything to do anymore. Same thing, just a slightly different mechanism. Vanco is not a beta-lactam. We'll come to Vanco in a little bit, but it's just a different way to look at a similar mechanism. All right, general side effects. Again, I said these are pretty well-tolerated drugs, and I meant it. Any antibiotic has the risk to cause some sort of GI-related side effects. So diarrhea and colitis are the two ones you're going to run into. Diarrhea being mild and hopefully short-lived. Colitis can be more severe, especially if you get C. diff colitis. It can be problematic. It can involve a hospital stay. It can extend durations of hospital stays if a patient gets it during the hospital. And C. diff was often thought for a while as a hospital-acquired bug, but we are actually seeing more and more C. diff cases from the community. So C. diff is something that we take pretty seriously, and you can prevent C. diff by washing your hands with soap and water in between patients. So certainly make sure you're following hand hygiene. It's really important. C. diff does not get killed by alcohol foam or gel. You have to use soap and water. So if you're ever in a C. diff room of a patient, soap and water afterwards for sure. Don't just alcohol foam. In high doses, beta-lactams can have some problems. You might have coma, seizures, some things like that, but this is really, really rare. Some of the drugs are more prone to cause this than others. Like, for example, carbapenems like imipenem might cause this more frequently, but generally in the doses we're using, in most populations, it's really a minimal risk. Renal dosing, almost all these drugs are renally dosed. If your patients have renal dysfunction, it's something that you will have to dose adjust. And again, most are pretty great for pregnancy and lactation. The one thing you run into a lot with these is the allergies, and we'll talk about cross-reactivity in a slide or two here. Basic penicillin is the first drug, so this is still a drug that's pretty useful today. Comes as two forms, penicillin G or penicillin VK. Penicillin G is penicillin benzathine, or just regular penicillin G, which is IV. So you could give penicillin IV. It's a drug that works great for strep still, so group A strep, like strep throat, group B strep, which is going to be something that you're going to be familiar with for your patient population for sure. We used to use penicillin for group B strep all the time. We switched out of it because penicillin doesn't come as a pre-made product. You have to compound it, and it's expensive. It gets kind of cumbersome on our staff that have to make all these intravenous products for the whole hospital, and so we just switched to ampicillin, which is more commercially available and more readily able to get stocked on nursing units and stuff like that. But penicillin is really great for your basic streps, and it's highly effective for those really basic gram-positive infections like strep, and also some meningococcus. Also useful for syphilis as well. It's still first-line therapy for that. Anti-staphylococcal penicillins are something you're probably rarely going to use, so I'm not going to spend a lot of time on it. These drugs pretty much just work on staph, and they only work on methicillin-susceptible Staph aureus. We're going to talk specifically about how to treat MRSA, MRSA, or methicillin-resistant Staph aureus. The methicillin-susceptible Staph aureus is a term for drugs that happen to be resistant to a certain group of beta-lactams, and those happen to be oxacillin, nafcillin, dicloxacin, and cloxacillin. So methicillin as a drug actually doesn't really exist. It might have at one point. We don't use it anymore. So the methicillin part is a little bit confusing. If you saw Staph aureus growing on a culture, you would look for oxacillin or nafcillin or diclox or cloxacillin. One of those drugs, if it came up resistant, that would be a red flag that you're looking at MRSA versus MSSA. So really these drugs are only used for MSSA, nothing else. Kind of the silver bullet approach. The only people that really order this are infectious disease specialists, so it's unusual to see this prescribed. Extended spectrum penicillins are really common, and for good reason. So you've got two different tiers of these. The top one would be your more narrow spectrum tier that's not going to cover quite as much bacteria, and that's going to be your amoxicillin or ampicillin. These bacteria have pretty good coverage against basic gram-positive and gram-negative organisms. And then if you add a beta-lactamase inhibitor, you extend the spectrum of activity. So the blues being the beta-lactamase inhibitor component. So amoxicillin in and of itself works fine for a lot of things. You add clavulanate onto it, and it becomes much more broad spectrum. Same thing with ampicillin once you add sulbactam to it. You just get a much bigger coverage rate of gram-negative species, and you also get some anaerobic coverage too. So it might be useful for things like intra-abdominal infections or mouth infections where you've got anaerobes living in certain areas of the body. Piperacillin and tazobactam is Zosyn, and that's one of the biggest workhorses as far as broad spectrum agents go. So we've gone from these drugs, which are used kind of for more basic infections, upper respiratory, maybe some GI type stuff, although it's not really recommended anymore. Strep infections, that's pretty basic stuff. Piperacillin and tazobactam is a really broad spectrum agent that's useful for a lot of things from sepsis to severe hospital-acquired pneumonia. It covers almost every gram-negative out there, including a group of gram-negatives that will sum up as saying pseudomonal coverage. So Pseudomonas is a opportunistic pathogen that tends to infect people who have weakened immune systems. It's commonly referred to as a hospital-acquired pathogen, and it's kind of nasty to treat. There's only certain drugs that cover it. So we put drugs into categories of, do they cover Pseudomonas or not? Drugs that cover Pseudomonas are generally considered to be more broad-spectrum gram-negative covering drugs. Drugs that don't cover Pseudomonas, less broad spectrum. It's a rudimentary way to look at it, but it is an important distinction in the infectious disease world. Does it cover Pseudomonas or not? We're looking at broad spectrum or possibly hospital-acquired infections. So if one of your patients delivered and they get septic post-delivery, a lot of times you might see them end up on Zosyn because Zosyn is a great broad spectrum agent that you can give people before we really know what we're dealing with fully. Don't worry about Timentin. It's not used very often. I just put it on there. It's sort of a Zosyn alternative that's not quite as good. But one difference would be that if you gave somebody amoxicillin or ampicillin, these are kind of interchangeable, PO or IV, even though they're different names. They basically cover the same things. Zosyn is only IV. You can't give an oral version of Zosyn. Zosyn extended infusion is a little bit beyond the scope, I think, of your practice in class. But you might see Zosyn dosed a little bit differently out there if you do have a patient on it. We do an extended infusion because, remember, beta-lactamase drugs are time dependent. So it really doesn't matter if we're giving big doses in regular intervals. We just want to keep the concentration above a certain point for a certain amount of time. So if we give the drug over a longer interval, it kind of makes it more of a continuous infusion almost. And what that gives you is more control over your MIC. You end up with a more consistent response, and actually evidence is showing you end up with a lot less resistance. It's probably what we should be doing with more beta-lactams than what we do already, but the evidence really isn't there. However, Zosyn's been studied pretty well, proven in that area. Okay, moving on to cephalosporins. Cephalosporins have a couple different generations. There's 1 through 4, technically maybe a 5th. Similar side effect profile to other beta-lactams. And generally speaking, when you go up in generation, you're adding on more gram-negative coverage. So basic first-generation cephalosporin probably has mostly just gram-positive coverage, minor gram-negative coverage, and the higher you get in generation, the more advanced that is. That's a general rule of thumb, but it's not absolute. Bacteria can be resistant to one lower generation cephalosporin, but susceptible to another. So first generation resistance does not rule out the whole class of cephalosporins. Names can be tricky. So Ceph versus CEF versus CEPH, they're spelled different. They all kind of sound the same. It can be convoluted. So make sure, especially if you're working in areas, most places people like to use their brand names. So make sure you really know what you're talking about. I've had a number of people mess up cephalosporin orders because they say, oh, I want Zinacef, and really they mean a totally different drug. And they're like, oh, I thought that was the brand name of that. Try and stick to your generic names if you can in this category, because it does get kind of confusing. All right, first generation, you have 2 drugs here, cephalexin, which is also known as Keflex, as the brand name, and cefazolin, which is also known as Ancef, which is the IV covered. They aren't exactly the same coverage. Cefazolin probably is more broad spectrum than cephalexin, but for the most part, we consider them interchangeable. These are really popular medications for a couple things. First of all, pre-surgical prophylaxis. So if you have any patients going in for a C-section, the odds of them getting Keflex Ancef, cefazolin are extremely high. It's a workhorse for us, for everyone in the country, really, when it comes to pre-surgical prophylaxis. The reason being is it covers basic gram-positives really well, and it does that job without really interfering with a lot of other possibilities for resistance or other bacteria. And so those gram-positives, specifically Staph aureus, and we're talking about MSSA, not MRSA, and Streptococcus. So group different types of strep, especially strep pyogenes, tend to live on the skin. So what we're really doing is we're trying to control any of those organisms, like if you cut open the skin doing an incision, those organisms that normally just live on your skin and don't do anything can get into that incision site and cause an infection. This antibiotic helps prophylax against that so that you're less likely to get an infected incision site. Keflex works pretty much the same way. Keflex is a really common skin and soft tissue infection. Basic cellulitis, Keflex is going to be your go-to. Unless your patient has a history of MRSA, Keflex will be the primary drug you're going to use for any type of basic skin and structure infection. Second generation cephalosporins, there's a bunch of them here. I don't really care that you know them too much. It gets a little bit convoluted as to when you would use them. An example I would have would be maybe a UTI. So maybe a first generation cephalosporin is resistant, but there's susceptibility to advanced generation cephalosporins. That's where a drug like cefuroxime can be really helpful. Cefuroxime, or Ceftin is the brand name, is an oral second generation cephalosporin that tends to have really good E. coli coverage. So it's certainly an option to keep in your toolbox for treating urinary tract infections. That's just one example of these. A drug like cefoxitin actually has some anaerobic coverage, so meaning it can cover belly organisms. So if you're talking about like intra-abdominal surgery, which again, not really something you guys are getting involved with at all, but it is a prophylactic measure we can use for that. Or for like a ruptured appendix or something like that, they might give cefoxitin, because it'll cover not only your gram-negative organisms and gram-positives like a standard cephalosporin, it'll cover some of the anaerobic flora in your bowel that could possibly cause an infection during a surgery or a perforated bowel, something like that. Third generation split into two categories. The first are not active against Pseudomonas, and but still highly useful. And ceftriaxone is really the drug we're most caring about here. Ceftriaxone is Rocephin. Rocephin is one of the most versatile antibiotics we use. It's highly effective as a community-acquired pneumonia agent. It covers Streptococcus pneumoniae quite well. It also has really good gram-negative coverage. So for patients who have pyelonephritis, this is a drug oftentimes they'll give an IV or IM dose of right away and then send somebody home on an oral medication. It's just going to cover pretty much every strain of E. coli out there. And that's, of course, our primary pathogen when we're talking UTIs. And in this case, ceftriaxone is going to be a really beneficial drug for that patient population. Now, it has a ton of utility. It's once daily dosed. It's not renally eliminated, so there's a lot of good benefits to ceftriaxone, but it's a good drug to keep in your wheelhouse as a regular one that a lot of providers like to use. Ceftazidime is an active drug against Pseudomonas. It actually loses some of its coverage, though. Its strep coverage isn't quite as good as ceftriaxone, so the only time we ever use ceftazidime is if we know we have pseudomonal infection and we know it's susceptible to ceftazidime. It's really the only time. It doesn't get used at all anywhere else. PO options, none of them work for no cephalosporin. PO will cover Pseudomonas. So when we're looking for coverage against Pseudomonas, or we're looking for cephalosporin coverage orally, third generations are basically just going to add on to a second generation coverage. You can get more gram-negative coverage, but really nothing too spectacular here. All right, fourth and fifth, cefepime is a really popular fourth-generation cephalosporin. It covers Pseudomonas. It covers all your gram-positives and gram-negatives pretty well. It does not cover MRSA, but everything else it covers pretty well. And it also doesn't really cover any intra-abdominal flora, any gut flora. So anaerobic coverage is quite weak. But other than that, this is a drug that a lot of people use for sepsis. They use it for empiric neutropenic fevers. Things where we have a really severe infection, we want broad spectrum coverage, but we don't have much more evidence than that. This is a drug that's used quite frequently. It's very popular, very well tolerated, and relatively inexpensive. Ceftaroline and ceftobiprole I'm not going to talk about much. Ceftaroline came on the market a little bit ago. It's the newest cephalosporin out there. Got some indications for skin and soft tissue, community-acquired pneumonia. It's not really used often because it's expensive. It got alternatives that are, for the most part, better and cheaper, so we don't use ceftaroline too much. Ceftobiprole is this magic drug that theoretically covers Pseudomonas, anaerobes, MRSA. It pretty much covers every bug on the planet. It's been approved in Europe for several years. Due to a lot of patent infringement and legal issues, it hasn't made it to the U.S. yet, but we might see it at some point. And there's some newer cephalosporins that are combined with different beta-lactamase inhibitors, but they haven't really seen the utility we thought they would yet, and I don't know when we're going to see them, but they don't really seem to have a great expanded spectrum, like compared to cefepime. We're still using cefepime. We aren't switching over to these drugs, so not sure if we'll see that change anytime soon, but for now, there are these drugs that might have an extended coverage compared to their non-coupled counterpart, but we haven't really seen that play out yet. All right, and carbapenems are massively broad spectrum agents. They cover basic gram-positives, but where they really shine is gram-negative coverage, where they cover your Pseudomonas and also Enterobacteriaceae, which are some of the most complicated organisms to treat. Bugs like Serratia, Enterobacter, things like that, some more unusual things that just cause nasty infections and have really high resistance to a lot of antibiotics. Again, not going to spend a lot of time on this because I think this is getting outside of our scope here, but these drugs could be used for a septic patient or a really sick person if they have, really bad pneumonia potentially. Where else we see these is for patients who are allergic to other cephalosporins or penicillins and have documented cross-reactivity issues. So maybe they haven't tolerated any cephalosporins in the past or penicillins. They have allergic reactions to all of them, or most of the major classes anyway. This is a drug that you can give them that has very low cross-reactivity. Sometimes you'll see these used even though they're a little bit more broad spectrum than you need, but you're going to get a safer drug on board that's less likely to cause the patient to have an allergic reaction. So up to 10% of the general population actually will report a penicillin allergy. And most often it's debatable whether or not this is actually a reaction. A lot of these people are reporting a childhood reaction that they don't really know what the real reaction was. They were just told their whole life, yeah, you're allergic to penicillin, don't take it. Well, what was the actual reaction? Was it actual anaphylaxis? Was it coughing? Was it hives? Was it something minor? Who knows? The other thing to think about too is that when people are actually tested for these, usually we don't have the luxury to do this, but there's been studies that say when you skin test people who report penicillin allergies, very few of them actually will react to a penicillin. So a lot of these allergies, while we take them seriously, somebody's like, oh yeah, I had a terrible reaction to that in the past. I broke out in hives everywhere. We generally take that seriously because we don't want to cause somebody an allergic reaction. If we have an alternative that we can get by with, certainly we're going to try and do that. Cross-reactivity is likely quite low. I said 2 to 3 for truly allergic patients. Some studies have shown maybe up to 10%, but that's really high. Others say that it might be as low as like 0.1% cross-reactivity. So it's sort of all over the place as far as what is the true number there. I don't know if we'll ever have enough data to really know that. People don't really study it because they don't want to give people allergic reactions. You can do stepwise approaches, but that's a specific protocol in and of itself. The other thing to think about too is that cephalosporins, the higher generation you get, the much less likely you are to cross-react. So somebody reports a penicillin allergy or amoxicillin allergy, whatever it might be, if you give them a first-generation cephalosporin like cephalexin, much more likely to react, even though it's still pretty rare, than if you gave somebody a advanced generation like cefepime. Cefepime would be almost impossible that you'd see a reaction. But we still take it pretty seriously. If somebody has a really severe allergic reaction documented to penicillin, we will avoid cephalosporins. Carbapenems have really low, like less than 1% cross-reactivity, so we will give a carbapenem to those patients in that case. You can do something called a graded challenge too, which is where you give 1/100th of the dose, see how they respond, give 1/10 of the dose, and if they're still good, then you give the remaining dose at that point. So it's an option. Certainly time intensive, and facilities can't support this in a lot of cases, but it is something that you could have done. You can desensitize people too, and those protocols involve multiple small doses over like a day or maybe a half of a day. They're very specific in how you give the dosing. But by the end of the desensitization protocol, the idea is that your body's not going to react to it anymore, and they're actually pretty effective. Sometimes you see that done for penicillin. There's some infections that certain drugs are really the only thing you can use. So one example would be like neurogenic syphilis, which is syphilis that's spread into the brain. We use IV penicillin for that. And while other drugs likely would probably work, there's no data to support it, and we know that IV penicillin works really well for it. So IV penicillin is the drug of choice, and if you can't give it to somebody because they're allergic, well, you're kind of out of luck. So in that case, you would want to do a desensitization protocol for those patients. Another option for severely allergic patients is something called aztreonam, which is a monobactam. There's only one monobactam on the market right now, It's really broad spectrum. It's broad spectrum, kind of like a carbapenem, but it doesn't really have anaerobic coverage. It's IV only, and this would be the true alternative for a severe beta-lactam allergy. So if somebody's allergic to carbapenems, if they're reacting to imipenem, you go to this drug. Otherwise, we don't use aztreonam. It's expensive, and that's its only role, is to serve as a broad spectrum agent that replaces a carbapenem in the case of a severe allergy. All right, so spectrum is really important. I've talked about this a lot. A couple things to think about based on what we reviewed. We talked about general spectrum type things, but specifically, we only talked about one drug that has MRSA covered, which is ceftaroline, which I'm not going to test you on, and I don't care, so you can ignore that, but it's there for your reference. Pseudomonas, we've got a few drugs that cover Pseudomonas. Anaerobes, and when I refer to anaerobes, what I'm really talking about for the most part is belly organisms. And the big one that can be pathogenic in the situation where you have some sort of intra-abdominal injury or infection is Bacteroides fragilis. That's the big anaerobe that can cause problems. And so in that case, when I'm talking about anaerobes, usually I'm talking about what covers Bacteroides. However, some drugs that cover anaerobes, for example, I didn't put a couple on here. Augmentin and Unicin, which is amoxicillin, or Unicin would be ampicillin, sulbactam, sulbactam. Those two would also cover anaerobes, but less. You see this more useful for anaerobes in the upper respiratory tract, so like for a dental abscess or something like that. But they all would cover Bacteroides generally, and some cephalosporins do it. Atypical pathogens are pathogens that don't have typical bacteria anatomy, if you want to call it anatomy, or structures, I should say, specifically related to their cell wall. And so they're more difficult. Conventional antibiotics don't necessarily target them correctly or effectively, and so in those cases we want to give a drug that's going to work a little bit differently. We haven't talked about anything that covers an atypical pathogen yet. We'll talk about that in a couple slides here when we get to those. All right, the next group we're going to talk about are some other agents that can target gram-positive bacteria and break down bacterial cell walls. So I mentioned vancomycin earlier. Vancomycin is, a lot of people think of Vanco, and specifically, you guys have nursing backgrounds. So if you've given Vanco, you might think of it as a broad spectrum agent, depending on where you've worked in the past. Vancomycin actually isn't broad spectrum. It's pretty narrow spectrum. Vancomycin only really works on gram-positive bacteria. It works on staph and strep, and that's about it. That's pretty narrow spectrum, actually. The thing about Vanco is it's useful for highly resistant pathogen MRSA. So it works well for methicillin-resistant Staph aureus, and it's our drug of choice for that. So when we're talking about covering people broadly, so let's again use an example of somebody who went septic, who maybe had a, let's say, post C-section, and now they're septic because they got an infection during the surgery or something, or maybe they had a pneumonia or whatever it might be that they got septic. A lot of times they'll add vancomycin on because empirically we want to cover MRSA in case it's a possibility. Your other drug is covering everything else. So, for example, if you give somebody Zosyn plus vancomycin, you're covering pretty much everything you could think about. But the only real thing the Vanco is bringing to the table is MRSA coverage, because out of all those broad spectrum beta-lactams, our cefepime, our Zosyn, our carbapenems, none of those cover MRSA. So we need something to supplement that, and that's where vancomycin comes into play. Note that vancomycin is IV and oral. Now, these aren't interchangeable, though. So Vanco is a really big molecule. It doesn't absorb well out of the GI tract. So you can use it as a topical agent in the GI tract, and that's useful for Clostridium difficile infections, so C. diff colitis. But other than that, you can't get systemic effects from that. And vancomycin, when given IV, doesn't really get into the GI tract either. So it's sort of like a one-way barrier there that you aren't going to cross. So you're either treating systemic infections with IV or treating the GI infection with oral, not crossing over at all there. A lot of hospitals and healthcare institutions have pharmacy to dose protocols surrounding vancomycin. It's kind of how hospital pharmacy got started way back in the day when when pharmacists would actually try and prove their worth and say, hey, we can do the lab work, we can look at the lab work for this and dose your vancomycin appropriately. So what pharmacists will do is we'll dose vancomycin based usually on weight and renal function, and then we'll get levels. So we get a level at a certain interval. Once we get a level for that drug, usually it's after 3 to 5 half-life, so 3 to 5 doses, depending on how frequently you're giving the drug. Once we get that first level, then we can extrapolate how frequently the person is clearing the medication. We can do 2 levels, so you can do a level starting shortly after you gave the dose, and then maybe a level 10 hours later before you're going to give the next dose, and then do some math to figure out in between there what the rate is and how fast they're eliminating it. And then you can figure out your dosing from there and try and extrapolate. Okay, so they're eliminating this much drug at this rate. I need to increase the drug by this much. Now that sounds complicated. Kind of it is. It's a little more simple than that in real life. We don't necessarily do all that math all the time, but that is sort of historically something that pharmacists took on. It's something we've retained for the most part. So we do a lot of vancomycin dosing. So instead of ordering, like if your patient needs vancomycin, you aren't going to order usually vancomycin 1,000 milligrams twice daily. You're usually going to order a protocol saying vancomycin pharmacy to dose and see what happens. Following along peripherally. Vancomycin may have some oto or renal toxicity at high doses. Renal toxicity is unlikely, and ototoxicity is also quite rare. Usually we target different levels for different infections. The more severe infections are like infections in the central nervous system, usually targeting higher trough concentrations. And then Vanco has a notorious side effect called red man syndrome, which is sort of like an allergic reaction, but not quite. It's not a full hypersensitivity reaction, and you can retry people if they've had red man syndrome. So actually, when we give Vanco, what happens is like their upper body, face, and neck, and upper extremities kind of turn bright red. What you do is you turn down the rate of the Vanco infusion. If that doesn't help, you give them some Benadryl. If that doesn't help, you might try something else. Or you stop the infusion for a certain amount of time, then maybe try it again. But it's kind of a weird reaction. I've seen it occur a few times, but it's not super common. Certainly notorious with Vanco, though. These other drugs I'm not concerned they're advanced coverage for things that Vanco wouldn't cover. So just to note, there are alternatives out there, daptomycin being one that you could use for some infections. These are usually restricted to infectious disease prescribing. They're expensive, and we want to make sure people aren't using them without trying something else first. So usually you can't prescribe these unless you're an IV doc. So anyway, these would cover MRSA, and that's really their point here. So that's why they're added there. Protein synthesis inhibitors are a group of drugs that kind of cover a wide variety of bacteria, so we'll work through them individually here. All right, protein synthesis inhibitors. So these are going to be working on different parts of the ribosome just to prevent different structures from being able to synthesize, therefore the bacteria will eventually die. Tetracyclines, first drug we're going to talk about, usually pretty straightforward. They're generally things we avoid in pregnant patients, though, so might not be totally relevant to your patient population. Mostly okay with lactation, though. Tetracyclines are, there's a couple different ones on the market. There's basic tetracycline, which we really don't use anymore. Minocycline isn't commonly used either, maybe only for acne. Doxycycline is probably the most common one. It's useful for a number of things. It covers a lot of really random stuff. It's sort of like a jack of all trades. It covers Lyme disease, anthrax, plague, malaria, a bunch of other stuff like that. As far as more conventional uses, skin, soft tissue infections, pulmonary, urinary, CNS infections, it's useful for all of those things. Doxycycline has MRSA coverage. It also has some just really good general gram-negative coverage. It's a very versatile drug, certainly worth thinking about if it's going to cover what you need it to cover or not. Don't worry about tigecycline. It's not used very much anymore. Macrolides, the one we're going to focus on, is azithromycin here. Azithromycin is a common ENT drug. It's got a bad rap because people use it, I think, a lot inappropriately, where they're giving it for respiratory tract infections that are more or less common colds. Azithromycin has a lot of resistance to strep pneumo in the community, and we don't use it by itself for pneumonia. So that's one thing you should never ever prescribe somebody if you suspect, even if they have a mild case of community-acquired pneumonia, they should never get just azithromycin. Zithromycin does cover atypical organisms quite well, and community-acquired pneumonia can be caused by atypical pathogens. The problem is a large percentage of community-acquired pneumonia can also be caused by strep pneumo, which azithromycin doesn't have great coverage against. So if you prescribe somebody just azithromycin, you're gambling that they don't have strep pneumo. And I can't tell you how many people I've seen come into the ER because they have a bad pneumonia and they're prescribed azithromycin monotherapy outpatient, and sure enough, it didn't work. Don't do it. Combine it with a cephalosporin. That's a good strategy to add your coverage so that you can cover both strep pneumo and atypical pathogens, or use another drug that we're going to talk about different classes here in a second. Aminoglycosides, not really commonly used, except still in OB. Every once in a while, these still get used. I think OBs gotten away a little bit from aminoglycosides and using some different things now. But for like endometritis, that's something that still sometimes you'll see a short course of aminoglycosides used for. Problem with aminoglycosides is in healthy patients they're actually okay. People with great kidney function, they work pretty well, but they are renally toxic, and if you have somebody on aminoglycoside for an extended period of time, their kidneys will have some damage to them. It's simply the nature of the drug. So we try not to use them for that reason, and ultimately they don't cover really anything that we can't cover with other drugs. We have a lot of good drugs out there that cover things that are a lot safer and better tolerated, like our advanced generation cephalosporins, like cefepime. Does pretty much everything an aminoglycoside can do without the side effect profile. So there's some benefit to not using these, and we're going to cause less harm overall if we avoid these in most patients. However, again, there's still some OB indications where the evidence would say, yes, we're going to be using these drugs specifically. Clindamycin is available IV and oral. There's no renal adjustment needed. And it's a drug that has some anaerobic coverage and also some gram-positive coverage. But generally speaking, its gram-negative coverage is quite weak. So it's a little bit of an oddball. But this is another one that you'll see used in OB. They combine this a lot with aminoglycosides for, again, things like endometritis. Some other agents that actually focus on gram-positives that work on the ribosomal system. Linezolid, again, another drug that's probably going to be restricted to ID only, but this is a vancomycin alternative for MRSA, and that's really all I'll say about it because it's something you probably won't be prescribing very often, if ever. Here are your spectrum updates. So we've added a few MRSA covering medications. We've added a Pseudomonas drug, aminoglycosides, and we've added some other things, anaerobes and atypical coverage as well. All right, other. Fluoroquinolines are probably the most popular class in the other. Ciprofloxacin, levofloxacin, moxifloxacin, they're all very commonly used. They inhibit DNA gyrase, which causes DNA double-strand breakage. So they have a different mechanism of action. Good spectrum of activity for the most part, fairly broad spectrum antibiotics. Problem is they seem to have a really popular amount of prescribing, which has led to some resistance in the community. These drugs tend to have more resistance built up than some other more robust agents we've had for longer periods of time. They also have some notorious side effects. They can cause hyperglycemia. They have a black box warning about neuropathic pain now, and they also have some tendon rupture history, which is probably pretty uncommon, especially in most healthy adults. I think there's originally some studies in developmental animal models that possibly says kids are at risk for tendon rupture, and then there's some case reports that show maybe elderly patients are. For the most part, unlikely to see that to be caused. Hyperglycemia for people who are diabetic, that could be a risk, and sometimes we do see sugar spike with fluoroquinolone use. So again, Cipro, Levaquin, and Avalox are the three drugs here. Differences in spectrum. Cipro is mostly just gram-negative coverage plus some atypicals. It also has some pseudomonal coverage. Levaquin does everything Cipro does, plus it has better gram-positive coverage. And moxifloxacin has MRSA coverage, plus it covers some anaerobic pathogens. But generally speaking, these have specific roles. Ciprofloxacin is common for urinary pathogen, but it works for a lot of other things. Levofloxacin and moxifloxacin, common respiratory agents. These are thought of as respiratory fluoroquinolones, and they're often used for community-acquired pneumonia. In fact, levofloxacin was one of our first-line drugs for community-acquired pneumonia. It covers atypical pathogens, and it covers strep pneumo quite well. So it's one of our drugs we like to use for that. It's also a once-daily dose, which is very convenient for people to take. Sulfa drugs. Sulfamethoxyl trimethoprim, IV PO available agent. A drug that has a lot of good gram-positive coverage, covers MRSA quite well. We don't use this in pregnancy, but it does work for skin, soft tissue, and urinary tract infections. However, its E. coli resistance is super high, like 20% usually or more. So we don't use this empirically unless we know it's going to cover it. And these drugs are just for your reference. There are some drugs out there that exist for highly resistant infections that, again, this would be IV only. You guys would never be prescribing these medications. But they do exist for people who have really resistant pathogens. Topical agents mostly are looking at gram-positive agent coverage, usually cover MRSA, things like mupirocin or bacitracin. Urinary tract infection agents only. Fosfomycin, nitrofurantoin work for these. Fosfomycin is an interesting one-time only dose. It causes cell wall destruction. It is an option for some resistant pathogens if they aren't going to respond or patient has allergies or whatever to standard therapy. And then nitrofurantoin or macrobid. This drug gets absorbed into the body and excreted. It has very minimal tissue penetration and very low risk of any type of side effect. Fosfomycin can be kind of hard on the GI tract. This drug's a lot better tolerated. However, people who are older, people with poor functioning kidneys, the drug needs to get through the kidneys to work. And unfortunately, if your kidneys aren't functioning well, the drug probably won't concentrate in the urine quite as well, and you might not get as good of efficacy from it. This is a first-line drug for the most part for pregnancy and young healthy women. For a long time, we use this in all forms of pregnancy, but lately there's been some evidence that says that in first trimester there might be some birth defect links. So usually second and third trimester is pretty safe with nitrofurantoin. Do not use this for complicated UTI or pyelonephritis. It does not penetrate into the kidneys very well. It pretty much just concentrates in the bladder. So for lower UTIs, great. Upper UTIs, use a different drug. Metronidazole is Flagyl, used for anaerobic coverage, so usually for GI-related bugs. So this is a Bacteroides coverage. So for GI surgery or any type of GI involvement, belly sources of infections, metronidazole is going to be one that can be added on. Some drugs you don't need to add it on, like Zosyn. Carbapenems already do a great job of covering belly pathogens, like Bacteroides. But a drug like cefepime doesn't have that coverage. You can add, or ceftriaxone doesn't have that coverage. So if you wanted to cover somebody with those medications, but add the anaerobic coverage on, metronidazole is a good choice for that. Some interesting information about their disulfur reaction. You can read that if you want. Basically, don't drink alcohol. Drinking Flagyl, it alters the metabolism of ethanol, and people will feel very sick while taking it. Some GI-only agents, you aren't going to really have a lot of experience with these, so I'm going to skip them. Final spectrum review here. And then we have a case we can go over quickly. Give me a second. You can pause this and read it. Here's some information for the case. Blood pressure, heart rate, temperature. Again, you can pause this and review it. I've given you susceptibilities for Streptococcus pneumoniae. And so here's some discussion, some takeaway points I think are important to understand about ID. So what's a common organism that causes community-acquired pneumonia? So the common organisms would be Streptococcus pneumoniae and your atypical pathogens. So atypical pathogens are commonly Mycoplasma, Legionella, and Chlamydia pneumoniae. Those three are the common ones that are thought of as atypical. Mycoplasma probably being the most common community-acquired pneumonia pathogen that's atypical. How important is this antibiogram? Let's look at it. Well, what does this say? It tells us the percentage of susceptibility here for the different agents we could use. So it does point you in the direction. What I'm trying to get you to think about is azithromycin. Don't use azithromycin as monotherapy. It's 50% coverage chance for strep pneumonia. So is there a preferred agent? Yes, we want to cover our pneumococcal. So I gave you a urine antigen test that's positive. But you probably also want to empirically cover atypicals too. You can't necessarily rule that out right away. So preferred agent, ceftriaxone would be your preferred agent here, giving you susceptibility data here, or any type of advanced generation cephalosporin could fit into that mold there. And then usually you'd want to add azithromycin on to cover those atypicals anyway. So that's going to be an important thing to consider. Implications for breastfeeding. So our patient here, 2 months postpartum and breastfeeding, and this would be something just to think about as you're working up patients and thinking about prescribing drugs. Katrina is going to do some coverage on pregnancy, some pregnancy-specific and lactation-specific things to consider. But for the most part, a lot of drugs are excreted into breast milk. Usually they're very small amounts, and most of the time it's quite safe. My sort of rule of thumb, can the infant take that medication? And if so, it's probably okay. But there are lots of references out there that you can look this information up into. So I'd recommend doing some of that homework on your own. Case 2, we've got a 34-year-old pregnant female, 3rd trimester. You can read the rest on your own here. So our considerations, does this case warrant empiric treatment, and what agents would be ideal? So when it comes to urinary tract infections, in the general population, we do not treat infections that are asymptomatic. We let them clear on their own. There's colonization, there's bacteria there, but it's not causing symptoms, no need to treat it. Pregnant women, we do because of the risk of vertical transmission. So what agents would be ideal? Let's talk about something first. You're going to do, so your plan basically will involve prescribing something and culturing your urine. So you're going to culture the urine and prescribe the macrobid. 2 days after that initial encounter, you get some sensitivities back with E. coli growing. Almost all urinary tract infections are caused by E. coli, so it's not uncommon. We're going to see, nitrofurantoin is, of course, resistant. Wow, what do you know, Chad? Why did you do that to us? Now we have to consider an alternative. So you need to change therapy. Well, yeah, it's resistant. So anything that's resistant, you're always going to want to change therapy. So that's something to watch out for. You want to pick something susceptible. So susceptibility-wise, you have a couple options. You have first generation, second generation, third generation cephalosporins. You have ciprofloxacin. You have gentamicin. So your patient is pregnant. Fluoroquinolones in pregnancy usually don't get along very well. We kind of avoid them for the most part. So let's take that off the table right away. Gentamicin is IV only. It's not appropriate for this case. So that leaves your cephalosporins. So cephalosporins are okay in pregnancy. And there's no reason not to do first generation cephalosporin. If you see ceftazoline as susceptible, you can assume cephalexin will cover E. coli quite well too. So cephalexin would be the drug I'd pick for this alternative for this patient.